Dean will be the first up after the live case. After the live case, yeah. Followed by Thorpe again. It'll be Dean and then Thorpe.
We're going to do the live case now from Phoenix with Dr. Rodriguez presenting another case. So we're very fortunate to have him help us today. He's very experienced at this. Welcome back, Julio.
Thanks very much, Patricia. Actually, we've been here. I listened to your talk, and I think Dr. Sharifi also. Thanks very much. We have a very interesting case, and actually this case is going along with your talk, Dr. Thorpe. This patient, if we go quick with the history, is 51, I believe. It's a very obese man. It's in a neighborhood of 300 pounds. He had, past November, a pulmonary embolization. He presented to the emergency room with the left deep vein thrombosis. However, they concentrated in the emergency at hands. It was very short of breath. They took him to the lab and did a pulmonary angiogram. I don't know, and he doesn't know if they used any thrombolysis or did anything to treat the PE. However, he ended up with a vena cava filter. They put him on anticoagulation with Coumadin. The left DVT was untouched, but since then, if we move forward with the next slide, the patient developed a very painful swollen left leg. And he developed, even in a matter of few months, an ulceration and abrasion of the skin with significant changes at that area. So they elected to manage him with Una's boot, and he referred that helped him a lot. However, the leg is getting bigger. He's still having some discomfort walking and some pain. Now, let me show you them part of his past medical history. Besides being a morbid obesity man, he has also some coronary artery disease. He has a congestive heart failure, has a couple of stents in his coronary. He's a diabetic patient. Surgically, there's not much of a history there except for an appendectomy. Now, let me show you the ultrasound that he had back in February this year. This is actually a picture. If we go back to that one, that's interesting. You can see he is on a prone position. He has this left thigh is bigger than the other one, and he has the skin changes that I mentioned to him, and he referred that has been improved over the course of the last few months. Now, this is his ultrasound. There's actually some chronic changes on the left side, starting from the iliacs all the way down. His apparently either recanalized or everything that was there went up into the pulmonary artery, but there's some chronic changes at level of the common femoral. Apparently there's something at the common iliac vein as well. Tibialis, some of the tibialis are occluded. So what we're dealing here after 8 months is with a chronic deep vein thrombosis. There's some reflux in the deep system now. Perhaps there's some damage on the valvular apparatus of this system. But if we move forward with this case, let me show you what we decided doing. I know that he has some changes in the common femoral, so I put this gentleman of 300 pounds on his belly. So we have a prone position, and we decided, if you look at here, do a popliteal approach. We use the ultrasound to guide our needle. It was a very straight and clean puncture on the popliteal vein. And I put a 9 French over a 035 glide wire. While we were waiting here, I decided to do an angiogram. If we can show you the first picture coming up from the popliteal, it's nice to see that the femoral vein actually is well recanalized. And you can see some of the valve is still there with some of the branches and tributaries. However, my wire gets stuck right at the common femoral vein. And beyond that point, we don't see much of a contrast. Now, if we move to the second, I advance a 5-French trailblazer catheter, and right at the groin, I injected a very large greater saphenous and profunda, and then you can start seeing flow that is definitely diminished. I have to shoot hard just to get that image right there. Almost impressed like there's some more problems and troubles right at the iliac veins. But what is remarkable here is the number of collateral and tributaries that comes up from the superficial femoral vein and the vicinity of the profunda vein. Any comments here, Patty, on this angio?
You know, I thought by the ultrasound that it might be a little more open than it is. I don't know if things have changed in the last couple months, but it didn't look that bad on ultrasound, did it?
Well, it does. It does look bad. Actually, let me show you now the runoff. I'm sorry, the ultrasound pullback that we did. So I introduced the ultrasound all the way up to the vena cava, and what you're going to start seeing there is the metal struts of the vena cava filter. That is the vena cava coming down, and coming from the cava down to the iliac, there's not actually much of a stenosis there. Again, some sort of flattening, but it's not as remarkable as it was in the case this morning. So this is the common iliac vein coming down. It looks actually pretty clean. There's a large tributary right there. And then suddenly, this is the beginning of the common femoral vein. It's almost obstructed right there. It's almost completely blocked, very narrow, and then open up to this big confluence of the superficial vein and the profunda. And this is then the superficial femoral vein. So we really are dealing with the stenosis right across the femoral vein, just exactly your presentation at that particular location.
Do you think that that was from the filter placement? Maybe?
The puncture, well, this is the left side. I doubted that they choose the left side to put the filter, knowing that the patient has a left DVT. I will rather believe that they use the right groin for that. But definitely that's the area where the clot was sitting there. Perhaps, we don't know. We don't have any studies 8 months ago to see how extensive was DVT. I know that the patient came to see you once, no? I don't know if you have any other information from this particular case.
No, but the ultrasound in February did not indicate a high-grade lesion at the common femoral, so that's why it's a little bit odd.
Yeah, the other possibility was, I thought there might be some thrombus material sitting in that location, but really, I use a 12-millimeter balloon. Maybe we can show that image and show you the dilatation of the common femoral. Can you do it live, so, I mean, in real time, so we can see the balloon? There was a waste right at that particular area across the femoral head that indicated that the patient really has a stenosis in that area. I measured with the IVUS above and below the stenosis, and it was 11 to 12 millimeter, right there in the middle. I don't know if you can appreciate that. There was a little waste in the balloon. I'm still having something residual right there at the top of the femoral head. Now, we're in the process to repeat the IVUS just to look at that area again. So let's just look at that in live. If you hold the wire back there. So you can see even with the IVUS, the superficial femoral vein looks actually pretty clean. And this is just the external iliac vein coming back in retrograde manner. We're now crossing this area in particular, and you can see, Dr. Thorpe, it narrows some, and there's some fibrosis or either old thrombotic material in that area. It's just a very short distance, though, and then open very big to that area below on the superficial femoral vein.
Yeah, it looks like there's some old debris still in the external iliac. Do you agree?
Yeah, I'm completely agree with that assessment. Yeah, there's something residual still lining on the wall. Let's pull this back. Let me have some contrast and get a picture after the angioplasty, which is something that we were ready, when we get live, we were almost ready to do. So let's look at that area. I exchanged the sheet for a longer one so we can get a better distribution of the contrast. So this is it. So that area right across the femoral is still narrow.
Do you agree? Do you think the external iliac is narrow? I do. Right where the hypogastric should be?
Yeah. We can look at that area one more time with the ultrasound and coming up. Ben, if you go live on the roadmap, we can assess this area one more time. All right, so we're talking about in the venogram, this is the tightest point right there. How much, I mean, how big is this area? Can you measure that for me? All right, so we have 7.5 millimeter. And the external iliac, so we can see there's definitely some areas there. I think it's more a flow pattern that gives us that image. I think it's pretty clean right here. If we can take another sample and measure that one. Now, it's an interesting case because it gives us to the controversy of should we put a stent across this stenosis, right, across the inguinal ligament. So what was that in measurements? So what is the panel think about a stent in this region in particular? So we have 11 millimeter diameter right there. Right at this point, the vein becomes bigger. If we do another measurement here, it might be in a 15 to 16 millimeter right there. So what you thought about stenting this particular stenosis? Or you think it should be okay with just dilate it up?
Well, I've been saying all along that the balloon angioplasty doesn't really do the job, so I favor stenting it from my experience. What do you think, Dr.?
Yeah, I just want to make a comment to avoid any nomenclature mistakes. We do not use the term superficial femoral vein anymore because we are talking about deep venous system and just femoral vein would suffice. Second thing is stenting starting because, as Patty said, there is external iliac vein stenosis, but not more cephalad. So if you cover the external iliac vein and then extend your stent into the common femoral vein more caudally and cover the second lesion, that's a perfectly acceptable approach. Extending your stent below the inguinal ligament is not an issue.
Yeah. Yeah. We've done both ways. I see the point of wrist stenosis on the stent. So we're talking about somewhere right here with the stent. So that gives us a length of possible 6 centimeter of a stent located pretty much at that particular area, just at this location right there.
I would throw out one thing. If you stent between the internal iliac and below the common femoral, and he has any problems with inflow, the stent will go down because the collaterals will go into the hypogastric and bypass the stent. And I've seen that a number of times. Have you ever seen that pattern?
Yes, I'm saying that happens, yeah. Most of the time that I have this kind of scenario, I'd rather go a little bit lower than that. I understand that there is a good pattern of flow going through that big profunda and great saphenous vein. I think it's acceptable in this particular case, right where I put my marker right there, bring the stent down to that spot. I think it's going to be fine, coming up starting from the external iliac vein.
You're going to go to the inner trochanter level?
Pretty much, yeah.
Okay.
All right.
I still think there's a... How high do you think that goes? Can you use a mosquito to point?
Sure. Let me have a couple of mosquitoes. You don't see, you kind of see the needle that I placed there? Still not a good marker now. Okay, I put a couple of markers so you guys kind of assess that. We can go back to the same image that we had. So I'm talking about, this will be my distal landing on the stent, and it starts somewhere here with the proximal in the external iliac.
See,
right
I
there.
think there's a... Julio, I really think there's a lesion above that.
Even above? Okay, well, let's go back to the IVUS here. This is right, I'm right there where the mosquito is at the top. That vein looks pretty clean to me. I mean, and even if I pull down some more, I start seeing the changes happening just right there. Right there, yes, I can see some fibrotic. Actually, there's a little flap right there from perhaps the angioplasty. But above this level, Dr. Thorpe, I think it looks pretty clean to me.
Okay.
Do you have any... What you see right at this area here on the external?
Well, I just see on the venogram the narrowing about another 6 centimeters above that, and it was concerning to me.
Yeah, there's an area actually that gets... Let me just look at that live on the road map again. Right here, there's the origin of the hypogastric. I think we can see it. Perhaps in the venogram looks smaller, but I don't think it looks any diseased to me.
Oh, okay.
Yeah, you see that? It's the origin of the hypogastric, and maybe give us this particular image. But by IVUS is pretty clean. I think the IVUS is a pretty good tool to look into those changes there.
No, I think you've looked at it better now. Thank you.
Yeah. Yeah, so we got roughly 2, 3, 4, 5, 6, 7 centimeter length. I think I can use here a 14 millimeter wall stent by 60. I believe it's going to be anyway a little longer than that. So is that selection of stent will be proper in your opinion?
Well, I'd use a longer one myself, Julio.
Okay, what will you use here?
Because if it continues to expand, it'll foreshorten, and then it'll be up right at the common femoral, right close to the inguinal ligament. I don't think you'll have any harm by going a little lower. What do you think?
Yeah.
Yeah, I think at least an 80 millimeter, at least 80.
An 80?
Yeah, then the nitinol stents are also an option too.
Yeah. Okay, let's see. We have a 14 by 80 right here of one of the wall stent. Yeah, you're right. Nitinol. We can have also. I used the EV3 before with 14. We have it here available as well. What you found? All right, bring it in. Mm-hmm. Yeah, I think we found pretty much the stent that we need here. In French. Very good. Let's open that one. So we have a 14 by actually 90. And further, after we deploy the stent, we can actually dilate it up to 14. And that will shrink the stent somewhat more.
Can you remind us what the transverse diameter was? Was it 11?
It was
9? 11?
Right at the stenosis was 11. Above that was 12.5.
Okay.
And below is almost 14.
Okay.
I have a question. I'm still sitting on the fence on stenting across the groin. What's the harm, and this is a question to the proponents of stenting, what's the harm of doing balloon angioplasty and giving a trial and see how the patient will do and stent them if the balloon angioplasty fails?
I can tell you from my experience, the recurrence and reocclusion is pretty high. Since I started putting stent at that location, I think the outcome has been better, in my opinion. I can speak for many others, but I know the concern is something that we don't do in the arteries. It seems that the vein behave in some way better than the arterial circulation. I don't know if any other of the panelists has any different opinion or agreement with this.
I think as long as you start it well above the inguinal ligament and extend down, the vein will be straight at the femoral head. I don't think there will be any problems with longevity. Tom, do you have any comments?
No. It's really long. All right. Seems a little long, but we can try to accommodate this.
You know, in my experience, Julio, I never get into trouble with too long of a stent, only too short of a stent.
Yeah, I know it's going to foreshorten him some more. After I touch it with the balloon, it will probably get into the needle. I know that's still way below that marker that I choose. Start coming up a little more. I'm going to pull down.
Now it's coming up. You're going to end right in the middle of the femoral head. Man, that's an advantage if he needs a heart cath.
Here we go. All right, let's get the 40 millimeter balloon and touch that. Yeah, definitely had a significant foreshortening. Now, one thing about the duplex is that it highlights or emphasizes the problem of the common iliac, something that we didn't see neither here in the venogram or the IVUS. Of course, this is all duplex. It's done in February. It's already several months past. So if that was a thrombotic material or something lingering from the previous DVT, perhaps. Well, today, this common iliac looks very clean. You don't think there's anything that we have to do about that area, don't you?
No, yeah, I was really surprised that it didn't look as narrow as we thought it would.
All right, so we're going to concentrate right here on this, the main area of stenosis.
It's very fibrotic, isn't it?
Yeah, it does. You just use the shoulder here of this balloon. All right. I don't think there's going to be any problem in that position here, but I'm going to touch that just to expand it some more. Do you do some timings on your ballooning, just like we do on the arteries? Any preference of timing that you inflated the balloon in a problem in a chronic DVT like this?
I usually use 30 seconds, and I cheat a lot.
Yeah.
I mean, you don't have a high pressure balloon. I'd just like to inflate it maximally, though.
Yeah. All right, I think that the end of a stent finished pretty much where our marker was.
You still have a stenosis of the common femoral. Does that bother you?
We're going to look at that with the IVUS right now. Let's just do a quick venogram while you guys put the IVUS in. You have to remember that we started with 7 millimeter. I found that the external iliac was only 12, and we dilated with a 14 millimeter balloon. So we're going to get the measurements again with the IVUS and see what's the lumen there. Yeah, numbers of the collaterals and tributaries are diminished now. So we have pretty much direct flow through the iliac.
Julio?
Yes.
I am wondering why the contrast doesn't clear through that mid-external iliac. It stays below that narrowing. Would you want to do another venogram?
Yeah, we can do that. All right, so we're going inside the area of stenosis right now. If you can just either magnify that or take a measurement here, Ben, of this lumen. If you remember, it was approximately 7 millimeter. It's now still, it's 8.5 now by 8.7. Okay, let me just look at the rest of the external iliac above, see if there's any other issue here. Well, the position of the stent right at the external. Yeah, the vein looks pretty clean to me. We're already in the vena cava right there. Coming back again. Down to the area of stenosis, and then to the end of a stent. All right, let's do another angio. If you can let it run, Van, you can show us a little more higher as well.
At least by the IVUS imaging, it looks like you got a highly fibrotic lesion and with a lot of negative remodeling, and just the balloon appearance on the post-dilatation makes me feel a little bit better. You went with a wall stent. A little more radial force there.
Yeah. Yeah, definitely there's some fibrosis and scar tissue in that area.
If it were me, I would stent the whole thing. I don't know. We could take a vote. What do you think?
Yeah, I think, Julio, just proximal to where you stented, just before the distal common iliac vein, before it bifurcates, there may be a lesion there. On your IVUS even, that was clear.
Yeah, that's the area where the hypogastric is coming off. We can dilate it. Let me have the 14 millimeter balloon again. Let's touch that area right there.
Patty, if you're concerned, do you ever measure a pressure gradient across it?
What?
Do you ever measure a pressure gradient across it if you're concerned?
You know, the pressure gradient, we don't do it very often because it's such a small change. It's hard to, I mean, it could be a 2 millimeter pressure gradient, and that could be significant in a vein. What I'm going by is the fact that the contrast is hanging up right at that level. And I know there's a caliber change, but it should go faster through a narrowing than a wide spot.
Right. I'm always surprised that when you see something like that visually, even though the vein doesn't look
Show me
that
the
narrow,
angiogram better.
I'm surprised how often we may get back a 3 or 4 millimeter gradient across that, which clearly would be significant in a setting like this.
In a vein, that is significant.
Yeah, well, I heard you say that you will stent everything. You mean from the external iliac down, or you including the common iliac pattern?
I would go, personally, because of that hang-up of contrast, which I don't think is a good sign. There are two ways. You can let him go and see how he does, and if he heals, it's great. Otherwise, if it's hanging up there, it's not a good sign to have the contrast not go through there quickly. I would stent all the way up to the cava.
All right, well, let's see what venogram shows after this dilatation. I can see there was something there, definitely. It's just the eye was this. It did fail to show much of it, except for the size of the external iliac right there. There was nothing that I can look at as a stenosis there. But definitely it's smaller in size right at that location.
It's a relatively small compared to the common iliac.
Yeah.
Any other comments from the panel here?
I'm more likely to stent the iliac than the femoral. So if you stented the common femoral, I think stenting the iliac is actually more important.
All right, this is the venogram. So perhaps move better to die at this location. Still looking smaller in size, isn't it?
Yeah, and you just really shouldn't have stasis of flow after you stent.
The IVUS one more time. All right. Well, I think we should go ahead then and put a second stent in that location. I think most of you kind of in favor of that, isn't it? So let me just grab. All right.
Dr.
Let's
Goddard,
put a.
Anybody in the audience have a vote?
It's going to be a low-risk procedure to extend your stent, and it's going to optimize the patency of the stent you put in at the hip. I'd vote for doing that.
I think we agree with that. Give us some measurements here on that stent. I think we used 14 earlier. That one is 15 centimeter by 13. So I think we can go with will you go with a 16 millimeter stent there?
1690? Yeah, I would.
1690. All right, so you're going to go very high on this one.
If you need more length, you could use an 1890, but you'll have to upsize your sheath probably.
Yeah, we have to change the sheath for that one.
I don't have any objection to putting another stent in, but I just wonder if some of this slower flow is just this very large patient in prone position with a lot of pressure on his belly.
Yeah.
Usually that doesn't explain the stasis of flow. I mean, the stasis is a bad sign. To a good result, you shouldn't have that. It's like a collateral that keeps showing up.
All right, let me just run this IVUS one more time. So here we go again. Fellows with the common iliac coming down. We're going to the place that I just angioplasty right now.
See, there's some stuff in the vein right
there. It's just a transition, right? The transition is just right at the hypogastric. You see, this is the hypo right there. It looks very big. Suddenly, it comes into the size of the external. I don't know you guys, but this doesn't look that terrible to me. The stent is widely open, well opposed. I think what I would do is I would give a chance to this patient and see. We follow him, and then we see how's he doing. I think that the main problem that this fellow had lies on the common femoral. I think we did the stenting. Hopefully that will stay open, keeping in his coumadin. But I think it's not a bad result, even at that area on the beginning of the external. I know that some of you are not probably in favor to put a second stent here, but I think we can just wait.
I think it's ambiguous. It is right where the artery is, and maybe in a different position there's more arterial compression than we're appreciating.
Yeah. I think that I think I'm going to finish right here. Maybe wrap the case. I'm going to follow him closely. I'm sure that you're going to look at him as well, Patty. And I think the main problem is being treated. Hopefully that will help with the changes on the skin, the edema, and the swelling that he had in the leg. But I think I'm pretty pleased with the results so far.
Yeah, I think it looks pretty good, and you can get an ultrasound. Patty Zenda can do an ultrasound before you pull the sheath. If you have anything else that shows up when he's on his back, you would then be able to still go in and do something.
Very good. All right. Well, I don't know if there's any further questions or some other comments.
Well, I don't know. We're all grateful. We've all been watching intently, so I appreciate all your work.
Very good. Well, my pleasure.
Effort.
Thanks for the invitation, and please enjoy your stay there. Thanks.
Okay. Thank you, Julio. Thanks, everybody. Super.
All right. Well, we're going to finish the afternoon with our remaining 3 talks. The first of which will come from my good personal friend and faculty member at Ohio State, Dr. Steve Dean, and he's going to talk about comorbid factors affecting chronic venous insufficiency. Steve.
Thank you, Dr. Rook. All right, so it's interesting, this topic, you really can't go and grab a review article on this. So came up with this based on things that I see time and time again in clinic in patients that have chronic venous insufficiency. And the majority of patients that have chronic venous insufficiency usually have one or more often than not several of these comorbid risk factors for CVI, and they are as follows: calf muscle pump failure, obesity, cardiopulmonary disease, medications, and or lymphedema. We're going to go through these individually. So calf muscle pump failure, I heard Dr. Thorpe refer to this earlier. I mean, what causes Dr. Rook's calf here to degenerate into this? Well, it's a lot of factors go into play. Well, first of all, peripheral neuropathy, intrinsic muscle weakness, immobility can all lead to calf muscle pump failure. But there's also interdependence among these factors as well. That is, peripheral neuropathy can lead to intrinsic muscle weakness. Intrinsic muscle weakness can lead to immobility, and the converse can occur as well. And then also you have to keep in mind that reciprocity exists between calf muscle pump failure and these cofactors. That is, muscle pump failure can lead to peripheral neuropathy, it can lead to immobility, and it can lead to intrinsic muscle weakness. Now also you would expect a patient that has calf muscle pump failure to have edema, right? It leads to edema, that's self-explanatory. But the converse can occur as well. A big swollen limb, it's hard to activate that calf muscle pump. So it can be the inverse. And likewise with lipodermatosclerosis. You have a big sclerotic leg, it's hard to contract the calf muscle. So again, it can go both ways. And here's a contemporary article published just last year looking at chronic venous insufficiency and how it relates to range of ankle movement by measuring the degrees of plantar and dorsiflexion and comparing it to several SEEP classes. And you can see on the y-axis we have range of ankle movement as measured by degrees of plantar and dorsiflexion. On the x-axis we have SEEP classification looking at groups 1 and 2 as well as groups 5 and 6. And it should be quite evident that the mean range of ankle movement significantly decreased as the clinical severity of the SEEP classification increased. In fact, you look at the C5, C6 group, they only have around 25, 30 degrees of plantar and dorsiflexion. And then also what's interesting about this study is the fact that abnormal range of ankle movement occurs early. Even in that C2 group with varicose veins, they already have some impairment of their range of ankle movement. Pretty interesting finding. From that same study, looking at CVI and how it relates to peripheral neuropathy, this table looks at the means for range of ankle movement. It compares it to neurological severity score and neurological disability scores. And you can see here that a patient that has severe C5, C6 disease has a neurological severity score or disability score that's 5 to 6 times higher than their C1 or C2 counterparts. So the clinical severity of chronic venous insufficiency is related to decreased range of ankle movement and the presence of peripheral neuropathy. which of course inhibits the calf muscle pump. Now, some of you may not be aware, some of you may be aware that chronic venous insufficiency can actually cause a peripheral neuropathy. That is, a chronic venous microangiopathy-associated hypoxic tissue occurs that provokes an ischemic polyneuropathy. This is associated with diminished vibratory sensation and impaired temperature sensation as well, which again leads to inhibition of the calf muscle pump. And then finally, here's an analysis looking at non-vascular risk factors for stasis ulcerations, and via multivariate analysis in about 12,650 patients, they identified that both rheumatoid and osteoarthritis, as well as peripheral neuropathy, were all statistically linked to the presence of stasis ulceration, presumably through inhibition of the calf muscle pump. It makes sense. Now, on to obesity. This is a somewhat busy slide looking at the SEEP classification as well as venous clinical severity score in roughly 1,400 patients with primary CVI and relates it to body weight. And we're just going to concentrate on the C4 disease in the interest of time. So if you took a patient with normal body weight, 7% of them had C4 disease, venous stasis, LDS, atrophy blanche, etc. Then you go up to your overweight category, 1 in 3 of those patients had C4 disease. You jump up to your obese category, 2 out of 3 of those patients had C4 disease. And that was a statistically significant difference between all of these 3 groups. So both overweight and obesity appear to be separate risk factors for increased severity in chronic primary venous disease. Now that begets the question, what is the pathogenesis that underlies obesity-mediated chronic venous insufficiency? This was alluded to earlier, but there are actually several studies that have been published over the last several years showing that obesity increases the intra-abdominal pressure, which inhibits the lower extremity venous flow parameters, specifically lower peak and mean venous velocity scores when compared to their cohorts of normal weight. It's also been shown that the obese patient is prone to popliteal vein compression. Obviously, they have decreased physical activity a lot of the time. That's linked to calf muscle pump dysfunction. And as we'll see in some upcoming slides, they often have comorbid cardiopulmonary disease. Now, here's a slide looking at the mean of calculated venous shear stress in the femoral vein of non-obese and obese participants. And as you can see here, the obese counterparts, when compared to their control group, have about half the amount of shear stress within their femoral veins. Statistically significant difference. Who cares if they have lower shear stress? Well, low shear stress leads to free radicals, which leads to inflammation, which leads to the characteristic manifestations of chronic venous disease. On to cardiopulmonary disease. Now, how could this evoke chronic venous insufficiency? As we know, patients that have heart failure, for instance, tricuspid regurgitation, pulmonary hypertension, often have edema, and as we talked about, edema can actually lead to calf muscle pump dysfunction, and of course the converse can occur as well. Now, when you talk about edema in the setting of heart failure, we talk about systolic dysfunction and diastolic dysfunction. Which do you think is more likely to be associated with edema? Well, it's actually diastolic dysfunction, as seen here, which is associated with transudation of fluid into dependent tissues, e.g. the lower extremities. So it's your diastolic dysfunction patients, often with associated right heart failure, that are predisposed to having significant edema, which of course can inhibit the calf muscle pump. And I think this is, at previous slides, a nice segue into this. If you look at the results from the Bond vein study, looking at the progression of chronic venous disease, these were the 3 main risk factors that were identified for progression via multivariate analysis. Age, that makes sense. Obesity, it makes sense. But hypertension, I mean, why would hypertension be associated with progression of chronic venous disease? Well, I think there's a couple things you could say. Well, first of all, they may be on vasodilators, such as calcium channel blockers, associated edema, which can inhibit the calf muscle pump. But I think it's probably more likely related to risk factors for diastolic dysfunction, specifically hypertension, as seen here. And also other risk factors for diastolic dysfunction include the overweight and the obese. But again, that link of hypertension with progression of chronic venous disease, something you typically don't think about. Somewhat busy slide looking at obesity as well as chronic venous insufficiency associated comorbidities. And this was a group of roughly 2,000 patients that were to undergo bypass surgery, and they subdivided them into ones that had no venous stasis disease versus a cohort that had, on the right, clinically manifest venous stasis disease. And as you can see here, patients that had either obesity hypoventilation syndrome or sleep apnea syndrome were significantly more likely, those were significantly more likely to occur in patients that had clinically manifest venous disease when compared to the ones that didn't. For instance, you look down over in the right-hand corner there, patients that had sleep apnea syndrome and venous stasis disease, 63%, versus only 21% in the cohort that did not have venous disease. And also in this study, again, look what was significantly linked to the presence of venous disease, systemic hypertension. 72% in that versus 46% in the patients that did not have chronic venous disease. Medications. Well, why are medications important? Well, because medications can cause edema, which of course can inhibit the calf muscle pump function, as well as the converse. And again, no way we can go through all these in the interest of time, but the big four, as I like to call them, that I see day in and day out that are associated with edema include calcium channel blockers, especially of the dihydropyridine class, but don't forget diltiazem, often under-recognized cause of peripheral edema, and even verapamil can rarely cause peripheral edema. Gabapentin or pregabalin in your patients with chronic pain, a lot of swelling, a lot of weight gain. Pioglitazone, and finally the NSAIDs. And then finally we'll end up on lymphedema. Well, how is lymphedema related to worsening chronic venous insufficiency? Well, this is an interesting statement. I think we see this time and time again. This is from a MedCAC summary on secondary lymphedema. In the U.S., the most common cause of secondary lymphedema is malignancies and their related treatment, for instance, surgery and or radiation. But contrast that with Dr. Farrow's statement that the most common form of lymphedema worldwide may be filarial infection, but the most common cause in the Western world is actually phlebolymphedema. I tend to agree with Dr. Farrow on this without question. I think anybody that sees swelling in their office would agree. And here's corroborative evidence from a lymphoscintigraphy study. 80 limbs, they all had chronic venous insufficiency in various classes, all the way from C0 or asymptomatic up to a C6. And if you took all 6 classes, overall, half of these patients had an abnormal lymphoscintigraphy. And if you only looked at the patients that had an active or healed venous stasis ulcer, 3/4 of these patients had an abnormal lymphoscintigraphy. So again, this coexistence of chronic venous insufficiency and lymphedema. So who cares? Well, again, a big swollen lymphodematous limb can lead to inhibition of calf muscle pump function. Well, what also happens with the patient that has lymphedema? They often get cellulitis, they often get a weeping hypersensitivity, eczematous dermatitis, and both of these conditions are associated with significant pain, which can lead to calf muscle pump dysfunction. And so finally, the typical example that I see, unfortunately, at least daily in my office is this patient. They have evidence yes, they definitely, you're right, they have evidence of lymphedema, but for some reason, can you advance it back there? I'm dead in the water here. Oh, no, we got to go back. Okay, somehow I've got 5 things going to pop up here. There we go, okay. So this patient has diastolic dysfunction, probably due to associated hypertension. They're clearly obese. As Dr. Thorpe pointed out, they have clinical evidence of lymphedema as evidenced by their foot swelling. They happen to be on pioglitazone, and without question, they have significant impairment of their calf muscle pump in a patient. That's the bane of my practice, actually. Anyway, thanks for your attention.
That's great.
All right. Our next speaker is Patty Thorpe, and I think just to remind people, they're thinking, do we have any other speakers here? Patty has been gracious enough to cover for one of our missing speakers. Dr. Francisco Assi couldn't make it from Brazil, so she's been doing yeoman's duty and giving extra talks here today. So, Patty, we'll bring you back up, and you can tell us about treating chronic venous obstruction below the knee, how to do it, and why it's important.
Well, thank you, Dr. Dean. That was a perfect lead-in to this talk because it also includes the importance of the calf muscle pump and the foot pump. So, without any further ado, I should disclose the fact that I'm the inventor of the tourniquet I'm going to show. We got a patent in 2001, and it's patented for its use with DVT. So that's part of my disclosure here. So this is a beautiful 3D image of veins in the legs by injecting pedal and IVs and doing CTA imaging technique. And well, I point this out because there are miles of veins. When you think about deep vein thrombosis in the tibia or the calf, you think, well, there's the posterior tibial, 2 perineal, 2 anterior tibial, so 6 veins. What's the deal? But the entire calf is full of hundreds of miles, probably, of venous conduits, which are all linked up together. So the other question I often ask people is, how many valves are there between your knee and your groin? And most people, there's 6 or 7, some fewer. But there are over 100 valves in the calf. And Dr. Strandis taught me that a long time ago, and I was very impressed, as you should be too, because those valves are there for a reason. They're to keep you from having big fat legs while you walk, because flow goes up 2 and stays there and keeps going up toward your heart instead of going up 2, back 1, as it does when people who have reflux. Very few people are born without venous valves. It is reported. I don't know if Dr. Rook or Dr. Dean has ever seen somebody with agenesis of the valves, but I mean, their legs are like elephantiasis. So the calf muscle pump and the foot pump are very important because they work in conjunction with these valves. So why is it important to treat DVT in the calf? Is to get rid of the clot that damages the valves that then screws up the muscle pump. So to me, it's very clear that we should be treating DVT in the calf. It's a source of pulmonary emboli, and it's also a source of post-thrombotic syndrome. It doesn't do any good to put a stent in someone's iliac vein if you leave their calf and their popliteal vein full of thrombus. So this is a nice slide, a drawing that shows the extents of the gastrocs and the veins coming up from the back of the calf and all the veins paralleling the arteries that join together and confluence into the popliteal. So when your muscles contract, they're to push blood through all of these veins up towards the deep system. And when you relax, the decrease in pressure is supposed to sump the flow in from the superficial veins into the deep system. So all that works in together. So we have 3 muscle pumps in the leg: the foot pump, which we just alluded to, the important calf muscle pump, and then the thigh pump, which is not as important as the other 2. At least that's what the literature would state. The foot pump primes the system, fills the lower leg veins. The calf muscle pump generates most of the push to drive the blood through the lower leg into the deep veins, into the popliteal and the deep system of the thigh. So in a normal person, the intact calf muscle pump is efficient, and it forces about 70% of the blood out of the calf as we walk. When that doesn't happen because the valves are plugged up or the veins themselves are thrombosed and atretic, then you're pumping against a brick wall. No wonder it hurts. That makes people want to sit down more. They get more obese. They get more diastolic dysfunction. It just goes in a circle. So in a normal system, it's like I just said, it works while your muscle is pumping, and then as it relaxes, the system fills up again, and as the muscle contracts again, it pushes the blood forward. So it's all designed to help us run and be able to get blood back towards our heart. Did you know in giraffes there are 2 hearts? One that's halfway up and one that's up above where the heart, you think it might be in a giraffe? It's because they're so tall they have to have muscle pumps all along the way, or 2 hearts in addition to muscle pumps. And one thing different about giraffes too, which is anecdotal of course, is that their skin doesn't stretch like our skin does. So what happens in the human leg when this reflux occurs and you get this osmotic pressure differential and you get tissue fluid is your skin stretches. It'll even outstretch a compression leg, a compression stocking. People get swelling even with compression on because it's such a great force, because we don't have inelastic skin like a giraffe does. This is a diagram, of course, of reflux coming backwards after the valves. It's supposed to circle here, close the valve door, and then be pushed forward with the muscle pump. But when reflux, of course, it's going back through the middle because the valve leaflets don't come together well enough. So this is a picture of a patient who had the double whammy. IVC iliac obstruction, a lot of clot from an old car accident, and then, of course, on top of that, he developed all this reflux because of the high pressure. And whatever valves weren't involved with thrombosis, they got damaged because of high pressure that was constant because of the obstruction above. Patient's only in his 40s. So the quality of life issue is totally significant. This is what his legs look like after we have opened up his IVC for the last 4 years. His IVC iliac stents that are open. So great improvement by just removing the obstruction. But his valves are damaged. He does not have diastolic dysfunction. He is not obese, but his valves are damaged significantly. So here is a venogram of a person who has DVT. I really like this set of slides because you can tell it's the same person because of this hardware. But after an orthopedic procedure, after a fracture, the patient developed DVT in the upper calf. Now, without a tourniquet on, you just inject a pedal vein to do a regular old venogram, and all you see is a saphenous vein. So you put a tourniquet on at the ankle, and then you are able to push flow into the deep venous system. Perineal veins coming up here into the popliteal. I'm not seeing very much little posterior tib, not much anterior tibulate should be coming in here. Those must remain thrombosed. But this is the levo phase, or the late phase, and I want you to notice how many other veins are showing up, what I call the no-name veins, and they're just miles of interconnections here. So what does that mean to us? It's like with the serendipity. Aha! If I can get contrast to go in those veins, why can't I get TPA to go in those veins? And if they all connect, that's great. How am I going to get a catheter in all those veins if they're all clotted? I mean, you can't damage all the veins with that many catheters. You couldn't even put them all in. I mean, that's an impossibility. But if you can deliver the drug through the foot IV and put the tourniquets on, maybe you can perfuse the entire calf with a very effective dose of TPA, urokinase, and get rid of the clot. And that's what happens. You put the tourniquet on here at the ankle, and you get this Cocket's perforator that goes right in like this, starts delivering contrast to the deep venous system by compressing the saphenous vein against the bone of the malleolus. And the tourniquet gets marked. This is actually the lady that was in the video that we showed. She had had the sclerotherapy down here, and we ultimately did treat her calf vein as well. So the tourniquet is marked. It has a little disc here that you can move around so you get it right in the spot you want it. Usually use gauze or a sponge. Put it right here, draw a circle. And then you can put it on like this, and you can put one on at the knee, and compress the saphenous vein against the condyle. And you can just perfuse the entire calf with a dilute solution of TPA and saline for hours. It's a marathon perfusion. Although the foot looks a little cyanotic here, it usually doesn't affect the pulse at all. But you do get some edema with the tourniquet. And you take it on and off each hour. That's why these are marked, so that the nurse can come on, lift it off, release it for 10 minutes, come back and put it on right to that mark. So they just know exactly how tight it is, because I determine how tight it should be, and then they duplicate that on and off. And it works. I've never seen it not work because the body likes to get all that lytic therapy just sitting in the calf, dissolving those clots. Chronic clot can be effectively treated, and acute clot can. Now, why does this work? It obeys the law, Possé's law. Possé's law says that the flow in a conduit is equal or proportionate to the fourth power of the radius. So if you increase the radius from 0, no flow, to 1, you've got 1 to the fourth is 1, but if you go up to 4, you've got 256 flow units compared to 0 flow units, or 1. So it's a logarithmic scale of increased flow, decreased resistance. So here's an example of a lot of clot in the perineal veins, just full of thrombus, actually quite dilated. This is the patient with the tourniquets in place, perfusing TPA, and this is the post-venogram, and that's in 48 or we usually go 48 or 72 hours. So you can see you've recaptured this venous conduit, you've lost how swollen it is, you've gotten rid of the clot. It really works, as long as the tourniquets are on tightly enough. If they're not, of course, it's not working. And we can confirm that as well with the increase in the duplex flow. So no flow here, almost no flow here, good flow with good augmentation. One more example of a little more chronic case. This is a case where you can see the chronicity is indicated by the collaterals here, and this is the post-flow. And what you've done is you've kind of recaptured or rediscovered veins that weren't there as well. And you notice that the contrast flows through more rapidly. So you know that physiologically you're changing the equation. Now, this last case I want to show you as a proof of the chronicity. This is a man who had knee surgery. I remember him well. He worked on the docks, and he was just about ready to retire. And he had knee surgery, and knee surgery went well, but he got a DVT. So he had good surgery, but he had a bad leg. So he finally came to me, and this was the venogram here. Almost no flow through this popliteal segment. Now, what I've always said about DVT venograms is the vein doesn't have to look perfect to work well. So we're treating the patient and how well it works. So we can't make it look perfect after a long series of, many days of disease, but we can make it work better. And that's what our goal is. Look at now, there's flow through the popliteal veins that were not even visible before, but after a few days of infusing with TPA, which is very easy on the patient, and it's a very effective therapy, no intervention except the TPA, you get this nice result. And I remember him hugging me so hard that he almost squeezed me to pieces because his passion was senior wrestling. He was a master wrestler or something at his age. Anyway, the protocol calls for sort of a low concentration, high volume to percolate through all those veins over a period of time, and it's kind of very effective. And the tourniquets are on and off, like I said, and the nurses are fine with it. They do it well. And the patient has is empowered to make sure that the tourniquets are on tightly enough. So I wanted to share that with you. It's a good technique. It's been around for years. We've had a number of doctors have it done on themselves, so we had validation in that way. I think Dr. Hunter talked about it last year. Anyway, thank you very much.
Well, we always like to save the best for last. I'm going to recall Gene Zeeler from University of Washington, and he's going to present our last talk of the day here on how to monitor iliac vein stents. Is it really necessary?
Yeah, it's kind of a provocative title. So it's been a long day and a good day, and somebody's getting paged. And so the only thing standing between you and the cocktail hour is this talk and maybe a little panel discussion. So I don't really have any disclosures except to state that since I don't do the complex venous interventions in our place, I collaborated with my partner, Dr. Mark Meisner, who does most of them, and we reviewed some cases and came up with some conclusions about them, because there really is not a lot in the literature about follow-up of iliac vein stents. So when I talk about follow-up in the vascular lab, it's important to define what we mean. And there are three terms that are used. There's monitoring, surveillance, and diagnostic testing. And clinical monitoring is simply doing a history and a physical and basing your recommendations on that. Surveillance is what we are usually talking about when we talk about follow-up, and that's routine planned serial testing after an intervention in patients that don't have any current evidence of a problem. And it assumes that significant abnormalities may not be detected by clinical monitoring alone, and also assumes that early detection and reintervention will result in improved outcomes. So it's really like a screening test. And diagnostic testing, of course, is the use of physiological or imaging methods in a patient with signs and symptoms. So vascular interventions have modes of failure, as you all know, that have to be identified and treated to provide the best long-term results. And follow-up after most vascular interventions is regarded as the key to detection of recurrent disease and other complications. And so the primary goal of follow-up or surveillance is to detect problems in an early stage, presumably when they can be managed most safely and effectively. Now, I always wanted to have something named after me, but after working away for a number of years, that wasn't happening, so I decided to invent my own name. Law, and that's Zieler's Law of Vascular Laboratory Follow-up, and that states that the optimal frequency of vascular lab surveillance is inversely proportional to the durability of the intervention. And so if you have a test that has a high restenosis or failure rate, then that turns into more tests, and that's generally true. And so there's some interventions that we follow fairly frequently because we know that they're likely to fail, and there are others that are very, very robust and that we hardly follow at all. So the challenge, of course, is figuring out where various interventions like iliac vein stents fall. So how do iliac vein stents fail? Well, they fail due to technical problems, improper stent selection, improper sizing, inadequate overlap, inadequate length, failure to stent all the disease. You're all familiar with that. And then they can either thrombose or they can develop in-stent restenosis. And so what is the evidence? Well, there's some evidence out there on how stents do. And this is a study that many of you are probably already familiar with, about 1,500 patients who underwent iliac vein stenting. And the results are very good. No deaths or PE, pretty good patency rates, better for non-thrombotic disease than post-thrombotic disease, good clinical results. And the factors associated with stent occlusion, again, are not terribly surprising. If the patient has had a prior thrombosis, males, recent trauma, and younger age tended to correlate with stent occlusion. And then for in-stent stenosis of more than 50%, very, very uncommon in non-thrombotic cases and occurring in about 10% of the post-thrombotic cases. Another study looking at reinterventions for iliofemoral venous stents, over 1,000 limbs, 177 reinterventions in 137 limbs. The median time to reintervention was 15 months. And the thing that struck me here is that 31% of the cases were detected by an abnormality on surveillance imaging. And this is a large proportion, but it's certainly not the majority. And 69%, the rest, had persistent or recurrent symptoms. So presumably they would have been picked up by clinical monitoring, as I've defined it. And you can see how the various reinterventions played out there. And then the lesions encountered during the reinterventions were extra-stent stenoses in about 58% of the reinterventions. So not all of these were in-stent lesions, and the iliac veins, not surprisingly, particularly the external iliac vein, were the most commonly involved. And what about the criterion for a venous stenosis? And I think some of the other speakers have alluded to this. There isn't really a lot out there on this in the vascular lab literature. There's a lot written about arterial stenoses, of course, but not so much about venous stenoses. And it's hard to come up with very good criteria. but this is Nikos Labropoulos' study, relatively small number of patients. It included both upper and lower extremity veins. And the best criterion he could come up with was, for a greater than 50% venous stenosis, was this pre-stenotic, or rather post-stenotic to pre-stenotic peak vein velocity ratio of greater than 2.5. And I think that can work pretty well, but I certainly have seen venous stenoses that don't quite reach that threshold. So here are a series of cases that Mark Meissner and I identified from our own experience, where we have some examples of vascular lab follow-up. Here's a case of left iliac vein compression. These are the pre-stent duplex images, and you've seen a lot of venograms today, but you haven't seen quite as many duplex images. The peak vein velocity is 56 centimeters per second, and I didn't put the ratio on here because it came out to about 2.2 or 2.3. It didn't quite reach the ratio or the threshold of 2.5, but you can see here that on the transverse images that the common iliac vein is pretty clearly compressed, and of course this was confirmed by IVUS and treated. And here are a couple of venograms from the stenting of that particular patient, pre and post. And we follow these patients initially on the first, either on the day of the procedure or the day following the procedure. So here's the left common iliac vein stent in a B-mode image, and it looks like there's probably some thrombus in the stent there. And sure enough, on color flow, there's actually a fair bit of thrombus along the stent wall. Another view of the same thing. But somewhat surprisingly, the velocities are not particularly elevated, and the flow patterns look relatively good. So this is not physiologically significant, at least not by those parameters. Here's the same patient at 6 months, and there's still some thrombus along the stent wall, but it looks like it's retracted or remodeled a bit, and the lumen is quite intact, and that patient didn't have any problems. Here's another case of left iliac vein compression, laminated thrombus. This is actually 2 years after stenting, and you can see in this image that the stent is particularly dilated in this particular segment, and the arrows show the thrombus. A couple of other images, including a color flow image showing the thrombus, and a normal flow pattern. So laminated thrombus in this setting doesn't necessarily mean that the stent is failing or that it's physiologically not working for the patient. This is another case. This is an IVC and bilateral iliac vein recanalization that Mark did, technically successful. You can see a couple of stages in the procedure there. This is 1 day post-stent, IVC image on the left, and right and left external iliac veins on the right. In this particular case, the iliac vein stents were not well imaged, but the flow patterns looked fine. 10 months post-stent, these are the IVC and the right iliac stents, color flow image and a waveform. The right side's patent. Unfortunately, the left side was occluded, and the patient was symptomatic. You can see in these images, these should be color flow images. There's a color flow box there, but no flow in the left iliac veins. You can see the thrombus there. So Mark went in and recanalized again the left iliac vein successfully. Here's 1 day post second stent procedure, or second recanalization and stenting procedure, and good flow patterns. And 4 months, the left side remained open. So, and you notice I didn't show you an in-stent stenosis, and we reviewed our last 20 or 30 cases, and I couldn't find a case of in-stent stenosis after an iliac vein recanalization. So they either remain patent, they get laminated thrombus, or they thrombose, but we just couldn't find a focal stenosis. So that just doesn't seem to be an issue, at least in that particular recent series. So the title I was given had 2 parts. How to monitor iliac vein stents. Well, there are 3 ways you can do clinical monitoring and look for signs and symptoms. And that is certainly worthwhile because the reported experience suggests that failure is apparent through that way of monitoring. Surveillance, I think, is somewhat controversial. I can tell you what we currently do. As I said, we get a baseline as early as possible, usually on on the day of the procedure or the first day. And then we tend to follow them at 3, 6, and 12 months, and then yearly. We would consider more frequent surveillance for high-risk cases, however you define them. And diagnostic testing is reserved for those with symptomatic limbs. And even if the duplex doesn't show something that's terribly concerning, if the patient has signs and symptoms, then further imaging is probably worthwhile. And then the last question, is it really necessary? Well, currently there's very little data to guide follow-up recommendations in this area. You know, historically, when I look at other kinds of surgical and catheter-based interventions that we've studied over the years, for example, carotid endarterectomy, initially we followed those patients very frequently, about every 3 to 6 months. And now we realize that the rates of problems are very low, and that we probably don't need to follow them very often. Infrainguinal vein grafts, we tend to follow those cases fairly often, because we know that particularly in the first year or two after surgery, they're much more likely to get into trouble, and that we can improve secondary patency by intervention. After EVAR, follow-up is extremely important. We tend to use duplex more and more for that, and we're getting used to using it in that context. Duplex scanning is obviously the way to go if you decide to follow your iliac vein stents, but the optimal follow-up schedules really haven't been established, and we will certainly need more clinical follow-up to base the clinical recommendations on. So that's it, and thank you very much.
All right, well, I have a couple of key announcements here. The first is that the cocktails hour will begin immediately after questions and answers here. And, you know, as any ultrasound, first-year ultrasound student knows, Zieler's first law deals with the inverse relationship between frequency of testing and frequency of failure. Zieler's second law is that you don't want to let the arterial folks beat you to cocktail hour. So we're scheduled to finish 5 minutes before they're scheduled to finish, thanks to our careful planning, and I think we should stick with that. So with that, I will open up the floor to questions here. Yes, sir.
I have 2 questions. One, Dr. Goswami, and I don't see Dr. Harry there, but I ask this question to the whole panel. A 57-year-old laborer was admitted after collapsing and was revived by the first aid people, found to have massive pulmonary embolus on both lower pulmonary artery, inferior pulmonary artery. On my way to the hospital, I asked them to do a stat ultrasound of the legs. It was not done, and the ultrasound was negative for DVT. Would you put an IVC filter?
Yeah, I don't routinely.
One, you should also make sure that the ultrasound extends to the iliac veins too, because sometimes they just do the groin to the foot. They forget the iliacs. But if that's negative, and you can be on anticoagulation and thrombolytic therapy, no.
No. And my question is that I didn't know whether it was done or not. But if you are the person over there in the evening, the technicians are usually very good. And if they tell you that there is no DVT, I'm sure I wouldn't ask them that, did you do iliac vein ultrasound? But would you put an IVC filter in that situation?
But is this a patient that can receive anticoagulation or for their pulmonary embolism?
Patient was immediately started on heparin.
Yeah. Is there any reason to put an IVC filter in that patient, even if they had clot?
So you will not put IVC filter, right?
Not if they can tolerate anticoagulation.
I thought you would say that.
I think the one reason you put a filter in, clinically indicated, is if one more PE would really be terribly detrimental and put them into heart failure.
Exactly.
After you get the echo, then you want to prevent that from happening. If there's any thrombogenicity that you can't control with the anticoagulation, or you could get a CAT scan to see if there's any residual thrombus.
Well, Actually, it was diagnosed after doing a CT angio. But I also did not put the IVC filter, put the patient on heparin. But at night, patient was intubated because of increased shortness of breath. And a repeat CT angio showed another embolus in the left pulmonary artery, upper pulmonary artery. And patient was intubated. Before we could do any thrombolysis, patient expired.
I agree with Patty. It depends on the amount of clot the patient had initially. So obviously that was a submassive. Was there any strain on the heart? If you think that the volume of clot is too high, I would put a filter.
Actually, the treatment of this patient is thrombolytic therapy. It's low-dose thrombolysis. That's what we've been advocating from the beginning. You shouldn't give them heparin or put filters. They get thrombolysis. Within 2 days, they're turned around. They go home.
So what would you do?
We have actually published this in several papers. It's called safe dose thrombolysis. We have simplified approach to PE. It's 50 milligrams of TPA rather than the standard 100 milligrams with a modified heparin dose. And then within 24 hours, they switch to new oral anticoagulants. We can talk about it later if you want to.
Okay. Another question is, have you had any experience with Cordis IVC filter? Cordis company. Instead of the filter which I saw today, a lot of complications with those wire breaking out, which looks like Greenfield filter. Have you had?
Did you say Cordis filter?
Cordis company.
Yeah, the Optis.
You
and
mean the
Trapeze?
Optis? Okay. Yeah, I have a lot of experience, and I'll present them tomorrow with the cable thrombosis and chronic and acute, and they have the highest complication, in my opinion.
I got it. Thank you.
Yes, sir.
So, I just wonder what you think about my opinion. I don't think you get edema from chronic venous hypertension unless there is certain amount of lymphatic overwhelming of the system. Even if you cannot prove it with a lymphangiogram, there has to be lymphatic overwhelming of the system to get that edema that you will get with chronic venous hypertension. So I saw that the study that you showed about 50%, but I think it has to be more than that. And
that study for 50% was all comers. That included C0s, 1s, and 2s. So you can see where that 50% may come out. But I agree with you. Your point is well taken. I mean, there's a thought now that I'm sure Dr. Rook would echo these thoughts that all edema is actually lymphedema, because you're exactly right. There's been a failure of the lymphatic system if you have edema. It just depends on whether or not you want to say they have clinically manifest lymphedema as evidenced by foot swelling, for instance. But your point's well taken. You could make a case to say, again, all edema is lymphedema,
okay, and
especially in the setting of venous insufficiency.
Yes, and then there was a very good study 2 years back presented at the American Venous Forum where they did a dynamic lymphangiogram, and it was done on people with chronic venous disease, and it was beautiful because you could see the amount of lymphatics that were not supposed to be there, and the other thing that they have reflux when it's dynamic. So I don't know if that ever got published, but it was people from the engineering department from Southwestern, and I'm still waiting to see that published and that technique available so we can really evaluate what the problem is. And then the other thing is that, in my opinion, all venous ulceration are ischemic ulcerations. And I was because of the milieu, because of the distance that edema causes, you have the same arteriole, the same system, and now you have more distance. The oxygen doesn't get there. There's an increased consumption because of inflammation. So I was just, so when I speak of this, and people look at me like I'm just crazy because they have palpable pulses. But to me, a venous ulceration, the reason why they don't heal is because they're ischemic.
Well, you could be crazy, but in this case, I think you're not. The fibrin cuff theory, dates back, at least 50 years. The idea that, fibrin exuding out creates a diffusion barrier. I think that's been disputed or debunked or whatever words you use, but I can tell you from my own firsthand experience, I've measured lots of TCPO2s in the area in and around venous ulcers, and you're absolutely right. They're always low. Now, you know, they're not as low as arterial ulcers, but there certainly seems to be a hypoxic component to all of these ulcers. And I've wrestled with that same question. How much of the damage to skin, how much of the failure to heal is actually due to hypoxia or impaired delivery or clearance of materials from flow versus just the high hydrostatic pressures versus some other factor? I don't know if anybody else.
Yeah, no, I agree. I mean, I'm thinking even from a clinical standpoint, think of atrophy blanche scarring. I mean, it's devoid of vascularization. That's why you said the few capillary dots there. And then also remember when I was talking about the peripheral neuropathy, it's an ischemic peripheral neuropathy, so it occurs on some small vessel level, obviously.
So I think that is greatly, underappreciated. The fact that, at the very least, hypoxia plays a significant role in perpetuating triggering these venous ulcers. Any other questions?
Tom, you're defying Zieler's second law.
Okay, well, we will evoke Zieler's second law. Thank you very much.